Welcome to this special episode of AMR Dialogues hosted by CNS and Global Alliance, or GAMA as we call it. Today, we are indeed honored to have amongst us the two co-chairs of the first ever WHO Civil Society Task Force on Antimicrobial Resistance. December and the Universal Health Coverage or UHC Day on 12th December, it is very important to put the spotlight on antimicrobial resistance, which is among the top 10 global health threats today, also threatening our food safety, security, and food systems, and polluting our environment. Without any further ado, let me introduce our honored panelists today. Catherine Orbez is among the two co-chairs of the WHO Civil Society Task Force on AMR. She is a former diplomat from the Dominican Republic and has been instrumental throughout her career in numerous negotiations and in developing public policies within various multilateral processes, with a specific focus on health, human rights, and environmental issues. She also served on the executive board membership to the World Health Organization. Tracie Muraya is also a co-chair of WHO Civil Society Task Force on AMR. She serves as the Deputy Director for Policy and Strategy for REACT Africa. She engages with policymakers, AMR stakeholders, and national and local AMR coordinating committees, including at the regional Quadripartite and Africa CDC. Tracie coordinates in-country projects in Africa which are implementing national action plans on AMR. Welcome, Catherine and Tracie. Before we learn more about the first ever WHO Civil Society Task Force on AMR, of which we at CNS are also a proud part of, let us first understand from our experts today why all of us should be so concerned about AMR, the impact it has on human life, plants, animals, and our environment. Catherine and Tracie, both of you are experts with years of experience in working on antimicrobial resistance. Can you please explain what is AMR or antimicrobial resistance and what factors drive it? And why should the public be concerned about it? Catherine, would you like to start? And then we will move to Tracie.
Thank you. Thank you very much. Thank you for the invitation to this conversation. If we have to define it in a simple way, AMR is when microbes, either bacteria, viruses, fungi, parasites, evolve to resist medicines. And we see this as a trending really complicated into the health system because we see every year cases increasingly every year globally. And there are many factors that affect AMR. Or the drivers we can identify. Some in terms of policy, weak regulation is part of it, inadequate sanitation, poor infection control, and in some cases, overuse and misuse of antibiotics in humans and animals. And that is exacerbated even in vulnerable populations and in conflict zones. And because the importance of paying attention to antimicrobial resistance has to do a lot on the public concern of what AMR brings. And that means that it threatens not only the health system, but basic treatments. And it complicates certain aspects within the health system, risking and reversing some of the medical advances that we have seen in the recent years. But in the position of more on the global level, if we look at the global aspect of AMR, and diplomacy coming in place, it drives political coordinations, it drives the mobilizers of funding, and also the intersection between science and policy of those processes that are being governance in terms of AMR. So that's my take on why AMR is so important and why we have to pay attention to it at all levels. Thank you.
Thank you. Tracie, why should the public be concerned about it?
Okay, just basically what my co-chair has said, Catherine, and then perhaps I could just sum it up. That at times it sounds so distant, unfortunately, when we're speaking about AMR. But I think what we all need to realize is in the next 25 years or so, at least the research is showing, by 2050, if nothing is done to address AMR and if we continue status quo, it means every 3 minutes, one of us will be dropping dead from a resistant infection. That means when I look at the screen right now, unfortunately, since we began this interview to now, none of the three of us really would be here if we're talking matters resistant infection. So that is why each and every one of us really needs to be concerned about AMR as it is right now, and the fact that we are still quite lagging behind in, the different aspects that Catherine has mentioned as a globe. And the disparities are also quite clear, unfortunately, that we find the higher income countries are, many steps ahead of the lower income countries. And still within those countries, within the high income and low income, we still have internal disparities. So, and because AMR knows no creed, no color, no status, no boundaries, it doesn't require a passport to be, transmitted from one person to the other. It means that really it doesn't matter whether you sit in a high income setting or a low income setting. If nothing is done about it to address it as it is right now, then we will be looking at catastrophic situation in a few years to come. I think that's how I can sum it up. And of course, because it affects all the standard development goals in one way or the other, whether it's directly or indirectly, their achievement is actually affected by resistant infections. Yeah.
Okay. Thank you, Tracy. Now, this task force was very recently established with 81 civil society organizations, and it is overseen by a 12-member steering committee. So, could you both briefly explain what are the objectives of this task force and what motivated WHO to start this? The floor is yours to both of you.
I can jump in first,
Yes, yes,
if
please.
that works. Um,
Yes.
I congratulate WHO for the efforts and putting in this civil society task force. And the aim is the really purpose is not only to engage civil society in terms of advocacy aspect and awareness sharing, but also how to engage into influencing the development of policies related to antimicrobial resistance. This platform, this serve not only to amplify the voices of what are this civil society doing, but how can we coordinate work between each other in that are from different areas, from different backgrounds, and support implementations of policies and strategy in terms of national and global AMR policies. Encourage also some of the aspects that are quite critical in terms of civil society engagement, and also to bring the gap between what happens at the technical level within governments and community, and also bring the real world experience into this global process, and as well how to bring those into the perspective of policymaker. So the diplomatic task force is a good platform to mobilize the awareness and advocacy of civil society and amplify the voice at the global level. I stop here and I pass it to Tracy.
Yeah, no, I think you've quite aptly put it. And to round it up, that, when all these civil societies are further capacitated, then the task force is better able to actually facilitate the uptake of the work of the WHO, it matters AMR and just health system strengthening by and large. So really, this is the main aim of the task force. And I know we have received questions. What is so different about this task force, for instance, when you look at this one and the CSO of the multi-stakeholder partnership platform, and perhaps even the WHO Commission for the civil society, basically. And when we had our inaugural meeting with the steering committee, which I believe, Shobha, you were there, yeah. Even the members appreciated the nuances that actually exist, as much as we may be working towards the same goal in terms of bringing civil societies together, but we still have a lot of work in terms of actually coordinating the civil society so that we ensure that there's actual accountability. What do we need to bring on board? This task force is now well placed to, for instance, champion tools such as bringing on board, a criteria checkboard, right? Where now we are actually really asking and following up for that accountability when our leaders go to the different forums where declarations are passed or different legal frameworks are actually ascended to, but then there's no sort of legal or rather formal follow-up when it comes to what should we be checking for. Do we need a checklist in place where we ensure that there's actually follow through, there's monitoring, and overall accountability to the work that is set out before our member states, our different member states, and of course encouraging civil societies to be on the table, at the table, to ensure that there's a whole of society involvement. Yeah.
Okay, thank you. Tracy, what, according to you, what is the unique value that civil society engagement will bring in the global fight against AMR compared to just government or technical responses?
Okay, I could start off by saying that unlike many other uh, um, organs, civil society and community, or rather, are literally part of the community. They are on ground. They are, for instance, some of them are the key opinion leaders within the communities. And if they're not, because of their day-to-day interaction with the communities, with the populations on ground, they are better able to actually understand the context. And so while at times or many other times that the governments will, yes, as much as they're, working to actually address matters for the population, a lot of it is at a high level forum or at the round table, as we say, at the boardroom level, but not really understanding the nuances that are on ground. So, for instance, if I come, let me just drop down to Kenya for the sake of this conversation. And we have a devolved government. And even when it comes to matters health, it is still a devolved system. What that translates is that as much as a lot may be going on at national level, if we're speaking matters AMR, we have a national steering interagency committee that is doing amazing work in terms of governance, policy, and just trying to coordinate everything. However, because of how our governance structure is fashioned, then we have the other layer of county leaders and county antimicrobial steering interagency committees. Now, what happens at national level does not necessarily directly translate to the CASIC or county level. And even when it does, the capacity is not necessarily as would be seen at national level. And then when you drop down again, even within the counties, you have now the sub-counties, etc. It's at the sub-county, at the village level that you find the CSOs. It's not necessarily at the national and at the proper county level. It's at the ground level. And so CSOs really come in with a lived experience that is actually on ground to be able to better inform even the policies that are being churned out from the higher levels. I will pass on to Catherine.
Yes, yes, please, Catherine.
Yeah,
Please, what are your thoughts? Yes.
thank you, Tracy. And I build up on Tracy, and I truly agree the need to the civil society. What it brings is really this community access. If we look at civil societies who are working at the grassroots level, And it's extremely important when we go to the grassroots level to really influence at the global level, because this is specific aspect of understanding communities and the knowledge that it brings in terms of fighting AMR is needed. And this is what is one of the biggest assets, I will say, in terms of civil society engagement at the community level. Also, there is the other aspect that we talk about of the importance of civil society, both at the community and at the global regional level, is this accountability and transparency process. And we see it as a mechanism not of blaming and shaming, but really to support and engaging into the process and commitments towards the implementations of policy for really tackling the AMR aspect. And that also includes the financial mechanism of how we tackle AMR in that sense. So the civil society is key in this process, in all the process, from the implementation of policies, from the design of policy, from the accountability perspective, for the facilitation of engagements and conversation, and even to bring in policy, science policy interface into all this process. So the value of civil society is quite key in all the discussions that we are having in terms of antimicrobial resistance.
Okay, thank you. So basically, local action is so necessary to achieve national and global goals. So the action begins on ground, and that is where the civil society comes in. Tracie, the task force mission includes amplify the voices of affected communities and ensure equitable access to prevention, treatment, and care, especially for vulnerable populations. So, who are the most affected communities, and how can civil society make a difference for the most affected communities? Because they are the ones who are generally left behind.
Mm. Yeah, who are the most vulnerable? Not to be shot at just because I'm female, but gender
Yes,
disparities
yes,
could really come into play
yes.
when we're thinking of vulnerable. And if I can just pack that a little bit, but then we also see the children under fives and the elderly population. Really, that sums up the vulnerable, and of course, people now living with disabilities. If I were to step back to the gender lens, um, even research has shown really it is the female gender that tends to one, either take care of the households, even when they're sick, they still have to take care of them. Two, uh, because of our biological makeup, then we tend to also, for instance, be more disposed or rather exposed to urinary tract infections, for instance, and sexual reproductive health infections. And so we tend to receive antibiotics more often than the male gender. Having said that, on the flip side, especially in our patriarchal societies, you still find that this disproportionately exposed gender is not financially able, or they do not really have the say when it comes to matters finances at the household level. And now we're talking at the grassroots level. So what that means is they may also have that infection, but they do not have access to the needed treatment for that infection. So these are the people we say that the CSOs really then needs to amplify their voice, and not necessarily as, and I love what Catherine said, not from sort of a loud way of aggression or such instances, but more of looking at both genders and building capacity for both genders. One, for the male gender, for instance, to understand um, um, what the female gender goes through at home. At times you find, I mean, it's not abnormal to find in the villages where the women are washing dishes by a dirty river, for instance, and the children are playing there, the under fives are playing there, they're drinking the same water. If you go up to the pastoralist communities, and the cows also, or the cattle are drinking from the same saline water source that even the herders are also supposed to drink from. And so it just exposes us differently depending on the context. Although mainly we do find for sure it's a female gender that is more exposed because of one being the caretaker at home, including of the sick family members, and two, being exposed just from the biological makeup. And three, also, when it comes to the workforce, we do find that the female gender comprises majority of the healthcare workforce at the bedside level. So tend to be more exposed. These are the people that we really need to speak for matters addressing AMR. I know I've not exhausted. Maybe Catherine can come in.
Yes. Yes, Catherine. Please.
Yeah, no, thank you, Tracie. And it's true that this is the most sensitive, vulnerable group that we see in terms of tackling AMR. I would add another complexity layer of this kind of complexity. We also see the vulnerable populations in indigenous community. That's also something to have in considerations. Migrants and refugees, and that also is linked to those who are in conflict-affected population. And if we look at the socioeconomic aspect, usually this vulnerable group that has mentions are those who are in low resource settings, and not only they are prone to have higher infections rates, some of the ones that already Tracie had mentioned, but also those ones who have limited healthcare access. So that's layered through layers of complexity in terms of the vulnerable populations that we are seeing. And that is why it is important to have this direct engagement with local communities who are able to reach that level of vulnerable groups and populations in those settings.
Thank you. Catherine, WHO has advocated for a people-centered approach to tackle AMR. Now, what is the importance of a people-centered approach, and how can it be different from what we have been doing so far?
So I go back to the same what I have mentioned. If we look at the complexity of those vulnerable groups, the complexity of the social determinants that are related to AMR, then we have to see this approach to really have strategies that are aligned to social, economic, national, and cultural context in terms of AMR. And that why is that? Because we need to these engagements to have in terms of implementation of policies and decisions at the local level. That's why this approach is quite important, to have that kind of different aspect of social and economic and also cultural in terms of implementation.
Tracie, would you like to add something to it?
No, just really to say that the same way we say with the CSOs, shouldn't be people-centered means it should not be a tokenistic transactional affair. It means the people are literally in the center of designing those policies, of implementing them through and through, so that there's that proper ownership and just listening to them. Actually, that's where we go wrong, I think. We want to bring a lot of expertise and not really listen to what the people need and want. As much as we may say, yes, we've done research as scientists, for instance, and we've seen objectively that this is a situation, but at times, the reality on ground, there's much more to the numbers. There's, the whole behavior change aspect that comes with, just this week actually in Tanzania, we're trying to stress on the importance of the different behavior change theories being applied. So of course, if you're looking at the combi model, is a capacity even there for them to be engaged in whatever intervention you may say that this is a people-centered intervention. If the capacity is not there, then is the donor or the person supporting them or the institution supporting them able to actually build on that capacity? Then what are the opportunities we find? And at times the opportunities are actually masked as as challenges or barriers, and maybe we're able to tag on these ones and tweak them to make sure that the communities, the populations identify that, oh, actually, perhaps this is more of a strength we have than a weakness. And then, of course, motivation. Yeah, what's in it for them? Why should they do it? Why should they wash their hands before eating? Why should the men perhaps also bring some money to the stay-at-home moms? Why do they need that money instead of asking for it all the time? What's in it for them? And of course, now that brings a behavior change and just tying up the people-centered approach that it's actually owned also by the people in whatever intervention is put there. Yeah.
Yes, thank you. So we really hope that the WHO Civil Society Task Force on AMR, it proves game-changing to shift the AMR response towards being more person-centered, led and driven by community, and which impacts change. That is what the hope, and maybe a tall order, but that is what we have to achieve. Yes. Catherine, according to the most recent global data from WHO, 1 in 6 of the lab confirmed bacterial infections globally in 2023 were resistant to antibiotic treatments. What does this statistic tell us about the urgency of AMR, particularly in low and middle income countries?
Well, that is not an ideal and good number. That what tells you is that we are seeing that there is an increase in terms of the severity and mortality in terms of antimicrobial resistance. Again, if we look at low and middle income countries, this is where we see the most vulnerable population that we already says. And what that means is that we are having a population that has limited access to diagnostic, to many aspects related to undetected and not properly treated disease. So that will, this what shows is that we are going to have exponential increase of AMR in the coming years, and that's what has been already predicted. And that is a number that WHO was able to put together. But one of the things that come into my mind is if we are seeing communities and population who have limited access to even collect this data, then it's even worse of what WHO can gather. And that is something also important to have in considerations, because data is something that is really lacking in those communities. It's quite difficult to measure what is happening in those communities as well. So what that says is that there is no longer, AMR is not longer something distant or abstract in terms of the health system per se. It's something that is completely a reality, is really worrisome, and is something that we need to be really paying attention all the time in terms to support the strength of the health system when we do investment and when we do our policies in terms to integrating those regulatories, improving of diagnostic infrastructures, and also the political engagement and the community engagement in that sense.
Yeah, Tracie, would you like to add something to it?
Just to, as Catherine has said, tie it all up in a nice little bow. It sounds very simple, but of course it's quite murky. Now more than ever, we definitely need to integrate, especially the data systems, the information management systems to do with health, whether it's at the lab level, health system level at large. There needs to be integration so that we, at a click of a button, anyone with the access, proper access, is able to see what is actually lagging. Is it that we managed to now get our diagnostics right, or the actual machines, but the evil that tends to be there's no sustained financing towards ensuring that there's actually an uninterrupted supply of consumables and reagents. And so what happens is that then we fall back on treating especially resistant infections without proper guidance from the lab. Then, of course, make sure that that dashboard is even easily speaking to the political class, to the policymakers, to the technical people, so that at a glance, everyone is able to see that actually the problem right now we have is more on IPC, more, compared to maybe the lab, or maybe at this particular region, it's more stewardship than anything else. And that way we are able to properly balance. I always like going back to HIV, the 1990. I know it's 95 now, but um, when we were doing so well as a region, when it came to undetectable viral load at some point, and then the first 90 became an or rather, I think got more funding, if I may put it that way, or got more gravitas in terms of preventing the infections in the first place. And what happened when PrEP was rolled out and the self-test was rolled out? The focus was so much on rolling these tools out that our communities and our populations started ignoring that actual protection in terms of whether it's protection in terms of not having multiple partners or using condoms. And what
Yes.
happened is that then the other 290s started falling. So there has to be that dashboard, I feel, that neatly ties up what Catherine was speaking to in terms of making sure that everything is integrated, whether we're talking of the traditional AMS, IPC lab, and then now the other factors around governance, leadership, workforce, etc. Yeah.
Thank you. The latest global antimicrobial resistance and use surveillance system, that is the GLASS report, which was released about 2 months ago, should not be just another report and a warning system, but it is also serving as a policy compass. So, this GLASS report indicates that resistance, one of the indicators there is, it is highest in the regions with weak health systems. For example, sub Saharan African region. So, Tracie, what are the primary drivers of this disparity between regions?
Sorry. Primary drivers really, from where I sit, um, is sustainable and innovative financing mechanisms in addition to political will and commitment. I really feel that when those two, and perhaps even the political will and commitment needs to come before the financing and everything else, because when the leaders buy into it and see the importance and how AMR affects everyone, then there will be that willingness to actually finance and to invest in AMR countermeasures from the different pillars, and that way then the disparities are not as they are right now. We have many competing interests in low resource settings. We have the highest burden of infectious diseases, but because our policymakers perhaps do not understand the gravitas of AMR, maybe that it's too scientific still, and that means we still have a lot of work to do at the advocacy level, especially as CSOs. Then our leaders need to understand AMR really, buy into it, not just signing declarations or accepting that they as member states that this and this will be done, but really understanding what it is so that then they can invest into it regardless of the competing issues. So we just spoke about integration. When the buy-in is there, when the commitment is there, when the understanding is there, then our leaders are better able to actually then plug AMR into national budgets, whether it's being integrated in the different aspects of health or other developmental areas. And then that way, less of the disparities will actually be witnessed matters AMR and what goes on to the international platforms such as GLASS and even the animal sector, what we see. Yeah. Over.
Okay. Catherine, how should these regional differences shape the global AMR strategies and response?
Well, I think we should take those drivers and see how we can use the leverage of this difference to really bring something that globally we are able to put in place in terms of the tackling AMR. And one of the things that we have to have in consideration is the magnitude of the difference. So we know that in different regions we have limited capacity of surveillance or laboratory data collection. I mean, Tracie put it out correct. I will put it: the political will and commitment is common in all the regions, and the financial mechanism might be different in some others. And globally, we see that there is not a trend of really having financial commitments in terms of tackling AMR. But what we have to see is that the drivers are mostly the same in some of the regions that have difference. Is the magnitude of it, and what are the most affected population, the vulnerable population, and why this driver comes into place. And I think this is what we've seen in the Sub-Saharan Africa, and then we were seeing in some other countries as well, especially in the small islands. Putting all these drivers together and understanding the complexity of the weak system, the inadequate prevention mechanism, and also the IPC that is in place. So if we put all these drivers together, we are able to really streamline what are the global action that are needed and understand this kind of gap between what it is in one region and what it is in another region and how that impacts. So I think we have to have in consideration those drivers to really compare on different regions and how to bring it together for really making a good case of antimicrobial resistance at the global level.
Okay. Catherine, one of the task force objective is to advocate for increased investment, as you have mentioned earlier also, in AMR prevention, mitigation, and research, and to encourage sustainable funding and political commitment. Now, given the competing health and development priorities, how do you plan to keep AMR high on the agenda, especially for resource-constrained countries and governments?
So again, is how we are able to reach to the not only politicians, but those who are working in academia, philanthropic organizations, donors, how we are reaching to them, what language are we using, what are the mechanisms, the communication mechanisms that we're using to explain the complexity, the severity of AMR. I think this is something that we have to have in consideration. And we also have to be quite smart in terms of not only center the discussion within the AMR community that already understands. So there is no added, I mean, there is an added value on the experience of the community in its own area, but there is another added value to engage other areas that affects directly or indirectly AMR work. So that includes speaking with health ministers, analyzing the economic impact. That includes how we design our universal health coverage system, how we design our pandemic preparedness system, how we even go even more in depth into health security, how we engage into the vulnerable population, how we speak with those migrants, how we speak with women health, child. So that is something that we have to do to keep it as part of the priority. How we integrate with other sensitive kind of issues that are happening at the social and political level. It's difficult. Is not an easy task, but we have to be smart enough to really put the case and give the message that is needed.
Thank you. Tracie, would you like to add something?
Just to say that in addition to Catherine's stakeholders that just said, as I like to call them, non-traditional, especially in low resource settings, which are mainly in sub-Saharan Africa, and Asia, we have an explosion of the youth population, over 70%, for instance, in Africa. So these are critical players that we also now need to bring on board. And I'm glad that the task force does have, for instance, the youth representation. And apart from the youth, it's actually quite encouraging to see initiatives such as the Fleming Initiative now also bringing in the primary school children. So we start at an earlier level so that everyone now understands. And then also non-traditional stakeholders such as the religious leaders. In Africa, we've seen religious leaders and their impact on HIV, for instance. And even the impact that's also not needed, for instance, when vaccine hesitancy creeps in, right? So it means they're quite influential. And if we can bring these non-traditional stakeholders together to understand AMR and how it affects each and everyone and the role that then the leaders play, then there's better what do you call advocacy towards ensuring that the leaders are actually walking the talk while the technical people are addressing what Catherine put out in terms of innovative financing, etc. But what are the leaders really doing? And so if we have the grassroots understanding and now advocating for these to move from paper to action, then I really feel we will be able to achieve what you've asked about. Yeah. Over.
Okay, thank you. Now, this task force brings together a diverse set of organizations, from global networks to professional organizations to grassroots level groups. As co chairs, where do you see the greatest challenges in coordinating across all these diverse groups? Over to both of you. Yes, Catherine, maybe you can.
Yes. Well, it's challenging when you are looking at different organizations that have different missions, get different areas of speciality in terms of work on AMR, how they are involved, in what areas they are involved, the size of the organizations. We in the beauty of that is that we have that quite diverse in terms of geography and regional representations. So I think it could be challenging, but at the same time, I see it as an advantage in order to bring good work together and balancing what we are aiming to do in terms of the work at the local level and also at the global level. But I see it's challenging to find a common ground when you have so much diversity. But at the same time, is a good opportunity to also understand and to bridge and to engage with different actors that you might not do it if you are on your own, and also to leverage this knowledge that the civil society comes into place to really bring together good communication, good work, and coordinated actions. It's challenging, but it is also something interesting, and that's the beauty of the civil society task force.
Tracie?
Yeah, the challenge, perhaps we could start by addressing through transparency. And I know it's easier said than done, but I feel that if that is not the cracks and really in the middle of our work that we do as a task force, being a transparent and already being inclusive, then we're bound to fail, really. But if everyone feels that everything that's coming through the task force or how it's being handled is actually is being driven by transparency towards the actual goal, then the challenge will be half addressed. Because remember, you're working with people in different settings, different mindsets, different priorities. Yeah,
Okay.
can leave it at that.
Yeah. Looking ahead to 2030, what are the main milestones or success indicators that the task force hopes to achieve globally and more specifically in high burden regions like South Asia and Sub Saharan Africa? We want comments from both of you on this.
Do you mind repeating that question again? Just framing it.
All right. What does the task force hope to achieve globally? The milestones or success indicators in terms of tackling AMR, and more specifically in high burden regions.
I could give it a shot and then
Yes,
Catherine can come in.
yes, yes.
First, I must say that in order to do this, the next plan, or rather the next point of action, my co-chair and I, is to, of course, together with the secretariat at WHO, is to draft a work plan for starters, because we need to figure out, an objective way of working, at least for the next 1 year at least. Having said that, I think by 2030, by the time, or even 2029, as we're going into the next UNGA, for the high burden countries, our priorities are quite clear, that it's not necessarily novel antibiotics. Yes, we need them and we need equitable access to them, but we first need to address the IPC strengthening, water, sanitation, hygiene strengthening of the infrastructures, surveillance. We might be doing surveillance in different pockets and getting even now really good data that's coming out, but we still have a long, long way to go. And just being able to standardize what's coming out of the different regions within the high burden countries, so that this can now also inform for instance, the priority pathogens at WHO level, which in turn also inform the pipeline for the new antibiotics or repurposed antibiotics that really need to be there. So I feel that for the high burden countries, really the priority should still remain the basics: IPC, WASH, workforce strengthening and development, and of course, then surveillance. Catherine?
Yeah, thank you, Tracie. I would look foresight into 2030, and if let's imagine we are in 2030, one of the big achievement that we could say that the civil society could bring at that time would be really how civil society was able to influence and achieve some of the really complex part of those areas of work on AMR, from the straining of AMR surveillance, IPC, as it was mentioned, the improvement of quality in diagnostic, the access to those already in place antibiotics. And that will be combined with other factors. If we are saying 2030, there is going to be another health social determinants that we hope that we can influence, and that could help in terms of reducing the numbers of AMR cases in those areas. But then if we look from now, I think the task force has already been really strategic in terms of saying this is what it happened and this is what we have to do. And it's true that we have to sit down to put in place a program of work that is feasible and actionable. And I will tell you that there is extremely a lot of appetite from all the members of the civil society task force to really be active and really make of this civil society task force a really enforcing group that has a voice, quite active voice, quite advocacy in that sense. So these are some of the areas that I see from now, and then looking foresight in 2030, a lot of work from us working in terms of influencing those areas within AMR.
Amen to what both of you have said just now, that it becomes true. What are your expectations from civil society organizations, even those who are not part of the task force, and media and public stakeholders globally about their roles and responsibilities in combating AMR? Catherine, you may.
Yes, if I separate by groups, I will say from civil society, not part of the is again is to engage, how to communicate, how to advocate with other civil societies who might have another focus that is not specifically AMR, but how we integrate them, how we collaborate with them to understand what they do, so that they can also understand what we do. and also to be part. I think there is a lot of work to do in terms of other civil societies in other regions that are not so active in terms of AMR. So that is something also to have in consideration. If we look at, you mentioned civil society and media.
And yes.
Yeah, if we look at media, I think we are in a crossroad of how we need to talk about AMR. And media is extremely important in that sense. And I think Tracie brought in how we engage not only with the media, but what language do we use? How we communicate? What is AMR? AMR might mean something for us who know it, but for those who do not know it, how we educate. So media is quite instrumental in that. How we use that to disseminate this language that is tangible, that is understandable, not only to politicians, they do understand it, but we have to give in another language to make it more important into the work that they do, but also how we do it to the general public, how we do it with health workers, how we do it within conflict zones to those, how we do it with donors to understand that this is part of the health system strengthening that they donate. So the media is quite essential in that sense. And I think that we have to be in tandem, civil society and media, we have to be in tandem to send the same message and to advocate for the same wording in terms of how we tackle AMR. I stop there.
Yes, thank you. Tracie?
Yeah, just what we want to see, even now, those that are not directly involved in AMR, but together through the integration that Catherine has spoken about, are we able to actually put in place all year round, perennial AMR awareness activities? We tend to really just blanket it under the World Antimicrobial Awareness Week, 18th, 24th June,
Yes, yes.
November, sorry. And probably that's really a task that I believe different CSOs, both directly and indirectly working on AMR, are able to innovatively come up with ways to ensure that this is an all year round topic, so that now people start understanding what we're really talking about and why we're terming it even as one of the top 10 global health issues. And then, of course, I really feel that there are those CSOs outside of AMR, and especially within, I believe, TB, that have really gotten it right in terms of community engagement, the framework tool that they use. Are we able to maybe tweak a framework tool that's out there for engaging communities when it comes to easy access of antibiotics at the community pharmacy level, because that's what ails especially the developing part of the world or the low income settings. Are we actually able to work with CSOs that are not part of the AMR fraternity per se, and get these two things right: continuous awareness and effective engagement of the community to make sure we have proper stewardship of antibiotics at community level. Yeah.
Thank you. Yes. And I just wanted to say something from my side. From my personal experience, I have seen even the media needs to be trained on what AMR is about and how to go about it. Because recently I was in a media workshop, and there one of the journalists asked me, what are the symptoms of AMR? So to that extent, means that set me thinking that we need to train them as well. And then, as both of you have said, simplify the language and simplify the messaging as to how it is to be conveyed. And Tracie, when you said about it should not be just during WoW. This is like at CNS, what we try to do is that every day, like the World AIDS Day or the TB Day, or there are so many days, we try to link, and there is an AMR component in most of them, and almost all of them. And so that is how we connect the dots and keep it an ongoing issue. That is, I think, what the media can do also, and not just wait for that 1 week of advocacy. Okay, now finally, a message from both of you for the upcoming Human Rights Day on December 10 and the UHC Day on December 12. What is your message? Yes, yes,
I'll give it a try.
yes.
Then Catherine can come, especially if I focus on the human rights issue. It's a no-brainer now. AMR is not just a scientific issue, it's both a justice and developmental issue, in addition to being, the health scientific part of a matter rather. So access to the right antibiotic for the right patient at the right time is actually a justice issue. It is a human right issue. Once we actually realize that, and of course, this can be brought about by establishing effective universal health coverage platforms in our different countries. Once those are in place and our patients, or rather our populations, are then able to access both antibiotics, the effective ones that they need, the tests that they need, hand washing facilities when they need them, then I believe, honestly, we will tackle AMR to great lengths. AMR does not just affect the person who's sick from a resistant infection, but just like other nasty global health situations, such as, not situation, but conditions, such as cancer, for instance. Cancer might be affecting that patient, but when you look at it, really, it is a family, it is a loved ones also who have to go through watching their loved one, in pain and literally wasting, and their finances also put to test, because ours is an environment that's more out of pocket paying. That's exactly what AMR does as well. It affects both you and I, whoever is directly infected by the resistant infection, and that one taking care of the patient or the loved one that has a resistant infection. So it's a you and I situation. It's a you and I aspect of life that we need to really look at as something that affects the entire globe. Yeah. Over.
Thank you. Yes. Yes, Catherine.
Yes, I think, yes, if we look, we have done a lot of advancement in terms of discussions on the right to health as an equity kind of component. But if we look, if there is a message, I will have to say that population have the right to have access to affordable medications, medicines, and also the right diagnostic, the right access to health system. But if I go a little bit more in depth, those of vulnerable population has that right. Not less than others, but we have to have in consideration the right of having access to that, the equity component. And if we go another layer, my message will be to really protect the right to health of those ones who are in conflict zones, who are having a high burden on antimicrobial resistance. So that's my message: the right to health as a main equity driver, right to the people's most affected in low middle income countries and low middle income settings, and those ones who are in conflict zone.
Thank you, Catherine and Tracie, for your time and for your such energizing insights. And as we near the year end, I think one of the positive developments of 2025 is the launch of WHO Civil Society Task Force. And with such means so much of woman power there in the chairing of that task force. So we are really look forward to 2026 and beyond, and impacting change to prevent AMR. Power to you all and to all of us. Thank you so much.
Thank you.
Thank you. Thank
Thank you.
you.